Good morning and welcome to the 23rd meeting of the Health, Social Care and Sport Committee in 2025. I've received apologies for today's meeting from Joe Fitzpatrick and Sandish Gohani, and Jackie Dunbar is joining us as a substitute. The first item on our agenda is for the committee to agree to take items 3 and 4 in private. Are members agreed? Thank you. The next item on our agenda is to take oral evidence from the first of 2 panels of witnesses as part of the committee's pre-budget scrutiny for 2026-27, and a welcome to the committee Emma Congreve, co-lead of the Scottish Health Equity Research Unit, University of Strathclyde, Professor Colin Mackay, Professor of Mental Health and Capacity Law, Edinburgh Napier University, Callum MacLeod, Senior Policy and Public Affairs Officer, Mental Health Foundation, and Craig Smith, Public Affairs and Policy Manager, Scottish Action for Mental Health. And we will move straight to questions. And Emma Harper.
Thanks, Convener. Good morning to you all. So I get to kick off today, and I'm thinking about within our health budget and our even mental health budget. I always feel that there are so many priorities to consider, whether it's child and adolescent mental health or community-based mental health support, adult mental health, and even now there's an increase in eating disorders. So I'd be interested to hear from you, what extent do you consider that the Scottish Government's strategy for mental health does set out the appropriate priorities?
I'll go first. Well, first of all, thanks very much indeed for the opportunity to come and give evidence to the committee today. The Mental Health Foundation very much welcomes that. We have a focus. We don't provide services. We're a charity, and we do focus on prevention, as we all do, and have an interest in that. I think broadly we would say that the overall focus in terms of the strategy's priorities is appropriate. Clearly, the focus on community supports, children and young people is fundamental in terms of that. The focus on suicide prevention, of course, is very appropriate as well. I think the critical issue is how we actually implement these objectives in practice and what difference it makes to people's lives. That sounds like a blindingly obvious thing to say, but as I'm sure we're going to come on to discuss, there are real challenges in terms of implementation, both within the context of the health and social care portfolio itself, in terms of what's delivered in practice. There are also challenges as well, I think, in terms of, frankly, the substantial amount of policy focus and resource and activity for impact that needs to be addressed beyond the health portfolio itself and social care portfolio. So I think there's a challenge really in terms of how we connect the priorities of the strategy itself to those wider policy portfolios as well, and get that cross-cutting dimension and make sure that actually comes in and has real, genuine impact for communities and individuals when we are, frankly, in the midst of a mental health emergency. And I don't think it's too strong to say that at this point. Thank you.
I can jump in if that's all right. I mean, absolutely agree with what Callum was saying. And I mean, fundamentally, I think the priorities for the strategy, I don't think anyone would disagree with them, particularly the focus on children and young people's mental health, community mental health. But as has been said already, it's how that is implemented and how that's linked to budget and spend as well. I mean, for us at SAMH, we are a national organisation and primarily deliver services funded through kind of social care budgets, but also beyond that in the community setting. And for us, we see kind of a long-running disconnect between really positive national policy and strategic objectives and strategic direction, and that implementation on the ground within communities, particularly around the resourcing of community services. We've seen that in terms of the real pressure on integrated joint boards, local authorities and health boards. So we may have really positive national strategy calling for more access and easier access to community support, calling for a prioritisation of suicide prevention. But when there's not that follow through and spend, we see local decision making really constrained in terms of what can be provided underground. I mean, for example, this summer, many of you will know about the real challenges in Edinburgh around proposals to basically wipe out the community mental health budget. Thankfully, those proposals didn't come to full fruition, but there are still significant cuts by the Integrated Joint Board for community provision. So I suppose it's just coming back to what has been said around how we link positive national strategy and policy to local delivery, and how we get that accountability right as well in terms of where we have Scottish Government and national policy pledges. I mean, we could take the 10% NHS target, the 10% frontline spend in mental health and NHS budget target, and that we haven't achieved that, and that lack of accountability because the Scottish Government, I suppose, rightfully says we can't dictate to boards what proportion they spend on, but they have set that policy. So is there space for more ministerial directions? I know ring fencing is quite a contested concept, but is there a role for that, particularly around areas like suicide prevention, which is rightfully as priority, but has very limited direct budgeting, and at a local level is very difficult to track what is being spent. And for example, in Aberdeenshire, we've seen suicide prevention spending cut entirely because it isn't a kind of statutory obligation on local authorities to deliver that, or integrated joint boards. So there's probably something we can do there about how we kind of tie up that accountability to strategic objectives and policy.
Thank you. So I'm here today representing the Scottish Health Equity Research Unit, which is a programme that focuses on the socio-economic determinants of health. So that's largely what I'll speak about. I'm also Deputy Director at the Fraser Vallend Institute, so I can maybe talk a bit about some of the specifics on budgets later on. So our focus is on understanding what we talk about as primary prevention, which is the upstream determinants. And as Callum alluded to, we have little understanding really of spend related to prevention for mental health out with the health budget. And so I think we do struggle to understand the breadth and the ups and downs of the budgets that relate to that space. So people's housing, where people are living in poverty, whether what's happening to people within the criminal justice system. There are many kind of aspects to this which are all relevant for mental health, and particularly one group we're focusing on at the moment with a big report out later this week is younger adult men who make up the bulk of the deaths from drugs, alcohol and suicide later on in their lives, and actually understanding we believe there's a lack of prioritisation of prevention for that group of people once they leave education, families and the care system, to help them integrate and thrive in their environments to prevent issues coming up later on. So that's one area that we feel is a bit of a blind spot for policymakers, but we're very much here talking about the primary prevention space, whereas colleagues here more expertise in the tertiary prevention space, which is the treatment side of things.
I'm here, I suppose, partly because I was on the Scottish Mental Health Law Review and we looked at mental health and capacity law in Scotland, but in looking at law, we quickly realised you couldn't do that, particularly if we were going to focus on a human rights-based approach. You couldn't do that without thinking about resourcing and how decisions are made in the mental health system. So the review focused very much on a human rights-based approach, including human rights budgeting to set priorities. That was one of its recommendations. And there's two things to say about that. One is about the process by which you decide on the priorities and how you engage with the affected communities in making those decisions. But it also has implications for what you do, what priorities you do set. And I guess if you start by thinking about human rights in human rights treaties, including things like the right to health and the right to independent living, you start by thinking about, well, who's furthest away from achieving those rights? And at the kind of macro level, the mortality and morbidity of people with mental health issues compared with the general population. It's been talked about for years, the 15 to 20-year gap in life expectancy. So, there's clearly a kind of urgent human rights need at the level of prioritising mental health as a general kind of priority within government expenditure. But also at the micro level, if we think about the people who are furthest away from having their rights met, you would think about, for example, autistic and learning disabled people who are trapped in hospital whose rights to independent living have been denied. There's a plethora of reports about that. When we engaged with people about what's needed, there were a number of things which came up which probably fall within improved community-based mental health support. People talked about peer support, about community wellbeing hubs, about open, flexible and accessible crisis and crisis prevention services, alternative places of safety for people in distress. And some of those things are, I think, in the strategy, some of them less so. But I think the broader context is the increase in need and the broadening of the definition of mental health concerns. I think this is something that the college put in their evidence. A lot of the people coming forward for services don't fit into existing services, particularly neurodivergent people or people with a complex range of problems, and particularly with issues of intersectionality, whether that's LGBT people with race. And so we need to see those as human rights issues. And I'll stop in a minute. I'm trying not to make too long a list. But I think a human rights-based approach would also say that we need to think about what people's current legal duties are, and there is clear evidence in the system that the system isn't able to fulfil some basic legal duties. Some of those are kind of about people's civil and political rights, such as having sufficient mental health officers to properly evaluate mental health and incapacity cases. But also there are already duties on local authorities in the Mental Health Care and Treatment Act to provide services to allow people with mental health issues to live normal lives and to promote their well-being. And it's not evident that those duties are being fulfilled, or even how you would count whether they're being fulfilled. So I think there are a number of issues which get thrown up if you look at this through a human rights lens, which would help us think about what the priorities are. I think, as other people said, it goes much wider, obviously, than the NHS budget. It goes into local authorities and into other parts of government.
Okay, thanks. Thanks for that. Callum, you mentioned social care, and Craig, you mentioned integration joint boards. Some IJBs do mental health budgeting differently. So I'm interested to hear what your thoughts are about whether, in terms of IJBs and how the budget is used, are there good examples or not good examples where IJBs are doing really, really well to budget for mental health? Is it effective? Is it joined up?
I mean, I'll come in and maybe unfairly can't give you a good example, and that's not to say there won't be. That I'm sure there will be. I'm just probably not close enough to it. I suppose some kind of poorer examples. Actually, the survey that was undertaken by SPICE ahead of the pre-budget scrutiny of IJBs in terms of their prioritisation of mental health spend was quite illuminating in terms of the lack of prioritisation taken by many of the IJBs, and I think our reflection as a kind of social care and community mental health provider, as well as a campaigning organisation, is that particularly over the significant years, but more the past couple of years, that fiscal constraint has been so challenging at a local level for IJBs that we are seeing significant cuts made without, from our perspective, a clear understanding of the rationale of the long-term impacts of that. So I mentioned earlier about Edinburgh IJB, which had proposed to disinvest significantly around their community mental health provision through the Thrive Collective, which SAMH are a part of. And when we were challenging that and working with the IJB over those proposals, there hadn't been, from our perspective, much evidence of an analysis of the long-term impact, including the impact on statutory services, about removing community mental health support, what that would have on the wider mental health system, and not just the mental health system, but other aspects of public service delivery and people's outcomes fundamentally. And ideally, and I think that's a more overarching point in terms of budget setting at the local and national level, there seems to be a lack of well, there's a lack of data around outcomes in terms of mental health care and treatment, both within clinical settings and non-clinical settings. That's not to say there isn't outcomes being measured, but there's a lack of consistent, systematic collection and publication of that to really inform service design and budgeting decisions. So I know I'm straying slightly off your point, but we definitely would welcome indications in the new population health framework and service renewal framework, which we think are fairly positive documents around a move towards a more needs-based assessment of the health and social care system, which is pledged, and a pledge to a more outcomes-based kind of model for service design. We need to see much more detail about what that means in practice, and if that's going to be fully inclusive of mental health and well-being beyond health outcomes, but actually people's individual outcomes across all aspects of their lives. So, yes, a slightly meandering answer there. There's definitely examples of bad practice, but partly I would say that is down to the significant fiscal constraint that IJBs and local authorities are under at the moment. And again, I point again to Aberdeenshire as well around suicide prevention, where there isn't that statutory duty or obligation to provide that support, and that's often been the reason that we've been given, for example, in Edinburgh and Aberdeenshire around proposals to reduce service provision. There has been a retreat to IJBs and local authorities having to really focus their funding on their statutory obligations, which is understandable, and not having that space to do that really important early intervention, preventative mental health and wellbeing services, which actually, if taken in a longer term view, would have a significant positive impact on their statutory obliged services, because if we are treating and supporting people's mental health at an earlier part in that journey, then we are going to decrease demand at the kind of more severe and enduring and kind of clinical end. So it's about having that long-term view, being able to see a system based on needs and outcomes.
Okay.
I'll be brief, but I want to preface what I say here because I'm conscious that you have colleagues coming in at the next session who represent, I think, an integrated joint board. I think they have a very challenging, we all are aware of the challenges that they face in terms of resources. It is not an easy, clearly, environment to be operating in. But it is, as Craig said, challenging to look at, to find positive examples. I'm sure they do exist, but they're challenging to actually identify. And the fundamental reason for that is there's a lack of transparency in data. It's difficult to actually see where the lines in terms of decision-making processes, outputs and outcomes are actually trackable. Really challenging to do that. The SPICE survey that forms part of your evidence in terms of the work that was done over the summer is really very sort of graphic in terms of just those inconsistencies. We have variations in terms of understanding of what prevention actually means within the context of mental health provision. We have very uneven elements as well in terms of how that's being put into practice. So for those reasons, there's a lack of transparency and real challenges in terms of just getting that kind of vertical link between what's being aspired to and what's being achieved in practice. So, and I'll finish in a second. So in relation to that, one of the critical issues is actually having consistency and a framework whereby you can actually get a preventative, in all areas, but particularly from the Mental Health Foundation's perspective, a preventative line running through that is transparent and can actually be followed through. And that's fundamentally important. I know that last year when your committee actually looked at pre-budget scrutiny, then you focused on integrated joint boards. And I think one of the recommendations that you made to government was, is there scope to actually have a preventative line in budgets? And I think the response was fairly, if I may say so, amorphous. And I think there is scope to return to that, particularly from the committee's perspective, I may say so, particularly given the fact that we now have a population health framework, as Craig said, that has a focus on prevention. We have a public services reform strategy that is absolutely saying we need to move towards definitively and decisively a preventative focus and have that. Well, if we're going to do that, we need to have the mechanics in place to track and how that funding and resources being used in practice. So it's difficult to get the examples, but there's a real opportunity to actually put the conditions in place in order to enable that to happen more clearly.
Okay, thanks. I'll stop there. Okay.
Carol Mockin.
Thank you, Convener. I really appreciate the discussion this morning, and you know that move to preventative spend is really important in how we track that. I have some concern that we perhaps don't focus enough on some of particularly human rights-based stuff for people with more mental illness and enduring mental illness. And so in budget, we can get very taken up by that space in terms of preventative and community-based stuff, and yet we know some of our long-term residents are still staying in long-stay hospitals. You know, that's a reality. You know, is there anything in the budget that we should be looking at that helps us to think about that quieter group, I suppose, where you don't hear a lot about how we're supporting people in that area?
Pick up on that. I mean, I think you're absolutely right. I mean, I think there are certainly people in hospital that shouldn't be in hospital. There are also people in the community living what we used to call lives of quiet desperation, who are surviving but not flourishing. And I think it's very difficult at the kind of global budget level for the NHS or for local government to think about how you kind of get at that. I think we need to think about how we incentivise the system lower down. I mean, I think it's important that we think about prevention on those kind of 3 levels, including people with severe and enduring mental health problems or complex long-term conditions. The people in hospital is not a vast population. I mean, that could be the kind of thing where, as the dread words ring fencing. I mean, I think where if you said we're going to fix this problem, you could fix this problem. I mean, I'm always astonished to think back about the hospital closure programme of the 90s, where we did a phenomenal thing in terms of shutting down those large hospitals over a short period of time with massive improvements in the quality of life for people. And as I think one of the witnesses said last week, that's partly through you have to double run that. So there are some specific problems, such as the complex needs people in hospital, where I think you can say we're just going to fix this. You know, we are going to actually allocate some resource to fix this. But I think when you look into the reasons why it hasn't been fixed, I mean, it's often the complexity of the system rather than the willingness to do something about it. It's, you know, you can't come out of hospital until your housing is sorted out, then you can't, even if your housing is sorted out, you can't come out until your social care package is sorted out, and then if your social care package is sorted out, that's got to be procured from somewhere, and then by that time your needs have probably changed and something else will have happened. So the kind of key thing, I think, is about how we join up the system in a way that hasn't been done up till now. Particularly for that group of people, but I think more generally, I think it's about how do we align the incentives across the system and have developed truly shared accountability so that you don't have the situation that you have now, which is, I'd like to help these people, but I can't really because I've got to concentrate on my core group, who are these people over here, and it's very sad that other organisation doesn't want to help these people either because they've got to concentrate on their core group. So I think unless we can actually think about shared accountabilities for outcomes, it's difficult to see how we'll make some progress.
Thank you, Convener. You want to come in?
Just really briefly, and absolutely agree with what Professor Mackay said. And I think one of our criticisms of the strategy, I think when it first came out and ongoing, has been that focus on that group of people living with severe and enduring or complex and long-term mental health problems is missing. And for us, we do believe there needs to be additional focus there. Anything that Colin said in terms of that joined-up support and care, preventing those blockages for people to who are within psychiatric hospital settings to access care packages. We see that as a long-running problem at that discharge point, but also actually people discharged from social care more broadly into independent living. And also there's this really significant stigma issue there that needs to be tackled. And stigma is a key priority of the strategy, but we think there needs to be more done, particularly for that population. I think anecdotally, well, there is a genuine, real lack of data around stigma broadly. I think we can say there probably has been a lot of progress around what might be called mild to moderate mental health problems. But CME, the National Anti-Stigma and Discrimination Programme for Mental Health, they did a big piece of research 2 or 3 years ago now, looking at people's experience of mental illness, and saw that stigma was absolutely pervasive, both in personal life, but also structural stigma in people's interactions with health services, mental health services, and other public bodies and settings. And that has a significant impact. So there's clear data showing that people's life expectancy, if you're living with a long-term mental health problem, is 20 to 25 years less than people who aren't. And there's many complex reasons for that, but partly that is a lack of access to support around treatable physical health conditions, potentially people not being taken seriously enough, a lack of physical health checks. We know there's been work done in terms of learning disabilities to introduce annual physical health checks, and that's been really challenging in terms of implementation, but potentially something similar for that group of people living with long-term mental health problems, where we know they're experiencing multiple complex inequalities and discriminations and challenges, to support people in all aspects of their health in terms of to tackle some of that long-standing inequalities would be really kind of key. And that does need to be a kind of policy focus and a budget focus in terms of getting that balance right between where we are spending.
Paul Sweeney.
Thank you, Convener, and thank you to members of the panel for attending today. I think we've already heard there's a consensus from the panel that the current data on mental health budgets does not give a clear picture of activity at a national level, and perhaps there could be improved connection between budget allocations and stated priorities for mental health at a national and local level. Feel free to correct me if I'm wrong in that assessment. The main source of data that we do have is Public Health Scotland's cost book. The latest figures are for the financial year 2023-2024. The 2023 report from Audit Scotland on adult mental health does highlight limited data and inconsistency in how spending is categorised, make it difficult to track spending on adult mental health. I note that the Mental Health Foundation's submission did also highlight this issue of data gaps and inconsistencies. And it's not clear that the government's responded to those data gaps. So perhaps, Mr MacLeod, could you highlight what we need to do, or what the government certainly needs to do to improve the data picture? It's one thing to criticise the lack of data. What would good look like? Can you maybe hint towards what that should look like? Is there other countries or other methodologies that we should emulate?
Well, it's a fundamental issue, isn't it? I think clearly we need to have a much better sense of what the outcomes are for people who are actually the recipients of services themselves. So what actually is that what difference is that making to them with regard to their mental health itself? So what qualitatively is making a difference in relation to that? So that's one element. That happens at the moment, but it happens in quite a sort of ad hoc sort of way, I would suggest, and it's not actually ingrained into the kind of evaluation processes in that sense. I'll give you one example of that, which doesn't actually come directly under the mental health portfolio, or the health portfolio for that matter, but nevertheless I think is very indicative of the way in which there's a cross-cutting dimension to the elements that we're doing here, and that's the Scottish Child Payment, which has just been evaluated as one of the 5 family payments, and which has in the report findings from the individuals themselves that say having that payment has had a significant impact upon their mental health and their happiness, which is kind of fundamental in terms of just their perceptual level of what their sense of that is. So that's a qualitative element with regard to that. We need to be clear as well in terms of what the actual throughput is and the outcomes in terms of other elements too with regard to across different elements of government. So what difference, for example, is the housing provision for people having in that sense? What are the impacts in terms of affordability there, the capacity to access that? What are the impacts in terms of other elements across different portfolios that actually have a trackable element with regard to it? So I suppose what I'm saying is, yes, we have challenges there at the moment in terms of we need a more coherent, structured approach with regard to a consistency of indicators, as it were, that allow us to actually track that in practice. And if you look at it from a macro level through to the kind of more meso and micro levels, part of that is about the national performance framework and where that sits, and I think that's up for potential review as well. And so how do the objectives there in terms of the outcomes there and the indicators there translate into the actual spend and the activities that are being undertaken in practice? So we just need a more systematic, robust approach to that. So there's no one magic bullet for that, but I think the principles of that need to be put in practice in ways that are consistent, easy to understand and accessible, but actually are impactful as well in terms of the types of outcomes that are being measured and the difference that they're going to achieve. We'd be happy to come back on that in more detail with the committee meeting as well.
So to summarise, more qualitative data and perhaps more contextual data,
yeah,
is what
absolutely.
you're saying. And Professor Mackay, perhaps you.
Just a small comment. I mean, one of the things that the Mental Health Law Review said was that certainly there is a problem about not having good data, but we also found that, and this is a quote, different bodies across the system are sitting on large pockets of data that cannot be accessed easily and are not routinely published or analysed. So it's not about not having any information, it's the information is in the wrong place or isn't accessible. And the review recommended a formal network of the many scrutiny bodies in the field, including Public Health Scotland and the Mental Welfare Commission, and that they should develop a cross-agency framework for monitoring outcomes in mental health care, so that's maybe a kind of glimmer of a way forward in some of this.
Can I possibly, forgive me, can I possibly come back and just follow up on what Professor Mackay said there? The data that's sitting there is, you're absolutely right, that some of it's there, but it's just not accessible in terms of it. One of the things that the Mental Health Foundation is calling for is precisely that, to have, given that there is activity across the different strategies we've talked about before, to have a coordinated approach to actually mapping out and having the contours, or the contextual and the specific kind of data that we need in a systematic way across government portfolios and vertically as well within delivery bodies too. So that's fundamentally important. The accessibility issue is really fundamental to this. We're calling it, the foundation is calling for a new strategic, innovative, improving Scotland's mental health fund. We'll be calling for that in a manifesto for the next election. But at the moment, there is a Save to Invest fund that the Scottish Government has in relation to prevention. It's mentioned within the Public Services Review Strategy. Now, maybe I'm looking in the wrong places, but it's actually really difficult to find out what that is actually funding in practice. And if you literally look for that to Google it even, the first thing you get are FOIs saying what's been spent on. Now, that to me is indicative of a kind of malaise culturally that we need to kind of collectively try and get through in order to get the kind of cultural change that we need to get the practical inputs in terms of the different measurement indices that we need to actually make our resources give as much value for money, and I'm talking about social as well as economic value for money, in practice.
Thanks. I'll just come in on some of the work we've been doing at the Fraser Vallender Institute, looking specifically at the understanding outturn expenditure. And this is relevant across Scottish Government, local authorities and health boards. There has, we feel to date, been a lack of utilisation of outturn audited spend, which is a process that all public bodies have to go through. And yet what is then presented publicly is much more limited. What Callum mentioned there in terms of how funds are reported, we often hear the announcements of funds, but then it's quite hard to actually find out what money was actually spent from that fund. So what did outturn look like compared to budget? We've got a huge reliance on just reporting budgets, saying we have put X amount towards this or X amount towards that, without that full accountability at a detailed level to understand whether that spend has actually occurred. And yet this information is available. It's, you know, there are processes by which public bodies, as I said, have to go through to satisfy auditors in terms of what's being spent. So I think there is potentially, to try and focus down on something that we know is there, and really trying to scrutinise that. That's what we've been doing at the Scottish Government level. I've been doing some work specifically on child poverty, trying to trace that money through from the strategies to outturn expenditure, with lots of gaps which we've pointed out. I think doing something similar for some of the mental health strategies could be a good way in to actually scrutinising what actually happened as a result of this in terms of audited outturn spend. And then it's a much easier task to then try and align that to outcomes. So has the money been spent in proportion to what the outcomes within the National Performance Framework or elsewhere within the strategies say it should be spent? But you do need to start somewhere. And this is so complex anyway. So it's for us, it was finding that route in that we could, with some certainty, start somewhere. I think going for that focus on outturn expenditure feels like a good place to go.
There is data there that is not being utilised to give a picture. There is an audit trail that can potentially be helpful in drilling down into outturns. Who takes responsibility here? I mean, that's really the issue about span of control. Often there's a dissonance between local IGBs, health and social care partnerships, and national boards, and then national level sort of collation of data. So where does the optimum balance sit? Does anyone have a view on what that should look like in terms of control and collation of data and publication of data?
So from our point of view, when we've been looking at things like the child poverty strategy, for example, which is locally delivered in many of its aspects, what we would say is because it's a Scottish Government strategy, it's based on Scottish Government set outcomes, that the accountability for understanding where the money has been spent sits with the Scottish Government. It's not to say that means there can't be local divergence. I mean, that's part of why we have localised systems. But in terms of who needs to know where the money has been spent, we think the book kind of needs to stop with the people that are setting the policy and the outcomes at that national level. So if they don't know where the money's been spent, what hope of the rest of us? So I think accountability is a real issue, and the public service reform strategy does talk about the need for better governance and accountability that goes across government and vertically and horizontally. So we think that is an issue that needs more attention and scrutiny.
Okay, thank you. I see nodding from the rest of the panel members in that respect.
Sorry, I can jump in briefly. I mean, basically to agree. I mean, in terms of where accountability sits in terms of national strategies and budget, I absolutely agree. Ultimately, Scottish Government, and where that data is generated will obviously come from a variety of sources, including providers themselves, and the third sector has a key role in that, local authorities and IJBs. But there needs to be some sort of systematic attempt at having coherent data sets, which goes beyond what we have at the moment, and not just to retread points, but in terms of what's not publicly available in terms of mental health system performance data. We have the mental health indicators, but broadly we have waiting times, referral numbers, delayed discharge. We're really lacking that outcome-based data, which I think we've all been calling for, and definitely, as has been said, is sitting there in various places possibly in very different forms. So there's a key role for government working with partners to have nationally consistent sets of outcome data that is available to help inform national planning, but also local planning for service delivery and reform. And there's definitely examples, back to your original point, of where that is happening in outcomes-based data. So, for example, down in England, for the NHS's Talking Therapies programme, national programme for depression and anxiety, there is routine patient-level outcome data collected and published at a national level, looking at recovery rates, looking at people's movement towards employment as well. So there's definitely models where that is happening in different areas. But as a system, as a whole, we need that fundamental shift to actually measuring what is the impact of what is being delivered, which I think we anecdotally know there's a lot of really good work being delivered, both in clinical settings, in third sector and community settings. But we just don't have that consistent approach to data and sharing of that data to allow good practice to be shared and learned from, but also to allow a more strategic approach to designing our services. I mean, at SAMH, we are about to launch our thing we're calling the NUC, which is going to be a network of walking mental health hubs. And we are going to be taking a really intentional approach to trying to manage and develop our data sets around the impact that the NUC, which will provide free access to non-clinical psychological support, group support, a wide variety of interventions without waiting lists. We're going to take a very systematic approach to trying to create the data about how that impacts people's own mental health and well-being, but also that wider system data in terms of what impact that has locally on access to wider mental health services and pressure on the statutory sector. But we need to be doing that on a more consistent basis as a country, as providers, so we have that national programme. And I think that does come back to some of the really positive stuff that we do see in the population health framework and service renewal framework about commitments to having a needs-based assessment of the health and social care setting and a desire to move towards an outcome-based model of system design. But we're still far away from how that's going to be implemented, and we haven't really got any information yet. So hopefully it's definitely positive that seems the direction of travel, but we need much more detail about how that will be operationalised in practice.
Okay, thank you. Thanks very much.
Brian Wood.
Thank you, Kavira. Good morning to the panel. I'm unsurprisingly going to continue the conversation around preventative spend and how we deal with that. I mean, I think we know that in Scotland we have a comparatively high level of economically inactive people, and a high proportion of that is around health. You know that I have quoted extensively Mental Health Foundation, the now dated Food for Thought, which you know, looks at the impact of food on mental health and SAMH's connection with physical activity. And we would recognise, quite sure everybody here recognises, that if we could tackle the economically inactive by preventing that happening in the first place, it means that, you know, there's more money coming into the system. But of course, that doesn't come to the health budget. So, in terms of the preventative spend, you know, 100% what we eat, how we move about, has got a huge impact on our mental health. How does that weave its way into the budget in a way that's effective, that we can measure? Easy question to start with.
A conference, isn't it? I think. In terms of that. I think you know, you're right to raise that challenge in terms of how it's weaved in practice. I think it goes beyond, as I say, the mental health budget itself, and I think it needs to be focused on what other portfolios well, let's look at the national picture in this sense. What other policy portfolios are doing in relation to preventative dimensions as well. So in other words, you know, the population health framework talks about taking a whole government approach. It talks about having a health lens in terms of looking at different types of activities. But we're not near that at the moment in terms of putting that into practice. So this sounds very dry, but I do think we need to have a situation where we are able to, where departments are able to actually identify what types of lines of activity they are undertaking, whether it is in terms of good food, whether it is in terms of physical exercise and elements there, that are actually have a preventative dimension to them, and actually can quantify that and actually document it in relation to it. And until we have that, it's going to be very, very difficult to actually move forward beyond, the warm words of prevention into practice. And we've alluded to it already, but clearly, and you've alluded to yourself, Mr. Whittle, in terms of economic inactivity and the challenges with regard to that and the profound dimensions. When there are people who are living in extreme poverty, and it's incredibly challenging for them to actually engage in ways that are going to enable them to make the most of their life chances, we need to think as well about how poverty kind of ties into this and the types of interventions that are going to help people to move out of poverty. And obviously we all, I think, share the ambition to fundamentally reduce child poverty in relation to that. So what are the mechanisms that are going to enable that, as an example, to happen? And I come back, it's not the only thing, because this is a much more complex set of issues. But when you look at the Scottish Child Payment and its impact in terms of having an impact on child poverty, that is a fairly fundamental dimension. It has an impact in terms of people in poverty who are in work and the opportunities that they have in that regard. So we really need to be able to kind of cut across the different portfolios, actually have transparency and accountability in terms of the types of activities that different portfolios are actually undertaking, so that we can start to track that in practice. And until we have that, it's going to be incredibly challenging to move that agenda forward, I think. So welcome the kind of the framing in terms of strategies, but more needs to be done in terms of the actual practicalities of that.
Just before I come, just so I can summarise what you're saying there really is that in terms of the overall strategy in terms of policy for the government needs to have a strand through all the other portfolios.
Absolutely, fundamentally that. And also, I'll slightly go further, if I may, just very briefly. Health in all policies, absolutely. Mental health in all policies as well. Mental and physical health are intimately correlated, obviously, in terms that we know that. So that's a very strong message. I would absolutely say the Foundation is pushing for.
So we've talked a lot at the Scottish Health Equity Research Unit about the warm words that are in many of the strategies on producing a cross-government approach to health, and then the realities of how the Scottish Government actually operates in quite distinct silos by portfolio. And I agree that actually shifting that to find a way where civil servants, the finance and the exchequer teams can actually grasp this in a meaningful way is going to be really difficult. I'm worried that it could go too far one way, in which every portfolio almost is claiming that it's preventing poor health. The entirety of the early years budget, as could be talked about as being key for child development and health for children and in later life. The entirety of the affordable housing budget could come under that. So we have to be really careful that we don't, by trying to do the right thing in terms of identifying how prevention works in terms of health, that we don't just oversimplify it. And unfortunately, what that means is actually a lot of quite nuanced work to understand the evidence on that comes from good quality evaluations that show where particular interventions feed through into longer term health outcomes. So the evaluation that was published by the Scottish Government on the 5 family payments on child poverty said it was a mixed methods evaluation, but actually it was mainly a qualitative evaluation, asking parents how they felt about, you know, what the payment had done for them, which is totally valid sort of evidence, but it's not enough in itself to really determine that kind of causal, whether the Scottish Child Payment is actually impacting on health. To do that, you need to compare it to a group that didn't get the Scottish Child Payment. So maybe a group in the north of England that's very similar in characteristics, to really look at then the differences in their kind of health outcomes. So there does need to be a lot more evidence-based thinking about how you do this. I know the Scottish Government is thinking about it, and the Public Service Reform Strategy talks about it. So we are looking for the spending review and budget this autumn to really be starting to set out from the government's perspective how they are going to do this, how they are going to shift to preventative budgeting in a way that, you know, that is robust and has consensus. And there are roundtables happening with Public Health Scotland support. There is activity happening here, but there is no easy solution. It's not just about moving numbers around on a page. It's about actually really understanding how what's the good quality evidence that exists that helps us understand what the long-term outcomes could be. My view is that actually starting with, rather than trying to tackle the whole health, housing and early years budget at once, is to look for where we're making marginal changes to budgets year in year. So start small, looking at where changes have been made and really understanding why that decision has been made, what evidence supports that decision. Say it's a change in priority for affordable housing, and then to really be tracking that over time to look at outcomes with good quality evaluation evidence. So it's a big task, and it needs to be broken down into small parts. Otherwise, it's going to become meaningless if you just chuck whole portfolios into a prevention bucket. So I think trying to find again that way in to do something meaningful that everyone can understand and get behind is a really important moving forward.
Yeah, I think, I've been around a long time in this, and we've been talking about prevention since at least Christie, and that's 14 years ago.
Yeah.
We haven't done it, and it's not because people don't want to do it. So I think we have to recognise there are some very big conceptual and practical obstacles. And I think perhaps starting with mental health and looking out to the wider Scotland around well-being is looking at either the wrong end of the telescope. So I kind of tend to agree with Emma that one of the things that we commented on in the review was that certainly in mental health services, but I think you could say this about public services more generally, is there's not been a lot of innovation and a lot of new things being tried over the last 10 years. In mental health, you can look at other international models of mental health services, of community-based services and so on. We don't see them here, so I think we need to build in scope to do some things differently and properly evaluate whether or not they make a difference and think about how we can scale them up across public services more generally.
Can I briefly come back?
Of course.
To clarify in terms of the qualitative quantitative dimension, I'm absolutely as one with my colleagues here with regard to the need to be systematic in terms of that approach that's taken, that's valued. But to come back to Colin's latter point as well with regard to innovation and opportunities and perhaps what's been slightly stymied in relation to that within the Scottish context, within a mental health cross-portfolio perspective as well, there are opportunities there, and I come back to the proposal that the Foundation is developing that is supported within Scotland's Mental Health Partnership Manifesto for the next election, which is on an Improving Scotland's Mental Health Fund, which is designed to do precisely what we're talking about there, which is to have strategic, innovative interventions that actually can be scaled up and put across different portfolios and different contexts, basically. At the moment, what we have in Scotland has been a very, very useful communities and wellbeing fund that's been running since 2020, delivered £81 million worth of funding for prevention, promotion and other elements as well, at a very localised community level, grassroots level, hugely important. But it's delivered essentially funding of £10,000 for community groups to do things. Brilliant. What would be very helpful to complement that sort of activity is precisely what Colin's suggesting there, this notion of being able to scale up, do innovative things, mainstream them, and see what difference that's actually making in practice. So I think there's an opportunity there.
Really small, quick question. Does politics think too short-term to be effectively preventative?
Sorry, say again?
Do politics and politicians think too short-term to be effectively preventative?
Well, we'll soon find out, because there's an election coming quite soon. But I think, yes, absolutely, because there are political cycles, aren't there, in terms of we see this actually in terms of Christie Commission, 2011, when that was first, when that report was delivered, in terms of, we're all absolutely familiar with what the issues are. We know there's pressures on services. We know there are different ways to kind of untie that Gordian knot, but we need to do it. But no one, for all sorts of reasons, is able or thinks they're able to kind of begin to do that. And if we don't start to look to the longer term and actually have the practical measures in place to address these issues, in terms of the unsustainability fiscally of public services, where you see the projections there, then we have got a completely unsustainable challenge. So, yeah, we need to think about political cycles. Other committees in the past in this Parliament have done similar inquiries, and we need to think about turf and resources and how different organisations actually are ready to collaborate and collate the resources for the common good and the benefit of all in that sense. So there's a whole bunch of issues there that are structural, that are cultural, and that are by no means easy to address, but we absolutely have to start addressing them in a meaningful way.
I think given we don't have a 3-day conference, convener, I'll let it go there. Hopefully come back later.
Patrick Harvey.
Thanks. Day 2 then on the same topic. I want to explore the same territory around prevention. First of all, can I just talk about the current state of affairs? The Mental Health Foundation's evidence says the policy dial has yet to shift decisively toward prevention, but you also say there is clear evidence of preventative spending activities in relation to mental health. Can I suggest that what we're seeing is some evidence of positive activity in what you might call discrete preventive activities, particularly in relation to individuals who are known to have challenges or issues in their lives, to try and prevent that from becoming much more serious detriment to their mental health. But what we're not seeing is decisions avoided which can create detriment to people's mental health in the wider sense. I mean, we've all talked about the pressures on IGBs and other parts of the public sector. Just in my own area alone, I've recently had to raise issues around cuts to community mental health teams, specialist trauma for people with acute needs, counselling for survivors of sexual violence. Glasgow MSPs have just recently been briefed that there's going to be a withdrawal of adult ADHD assessments. I'm constantly getting contacted, in particular by people waiting for gender-related healthcare, who are being told they're going to have to wait many years even to begin to access the process. So there is some positive preventative activity happening, but there is also a great deal of decision-making which actively undermines people's mental health. So we're firefighting while setting fires. Is that a fair analogy?
Yes, that would be would basically summarise our position in terms of there's good stuff. It comes back to, I think, what I said one of my first interventions. There is really positive policy direction. There's a lot of great stuff in the mental health and wellbeing strategy and in the suicide prevention Creating Hope Together strategy. but there's a real disconnect about people's experience of mental health care and treatment and support more broadly, and all those intersectional aspects that you mentioned on the ground. And partly that is due down to budget alone. We see local budgets hugely constrained over the past few years, which just really impedes the ability for IJBs, health boards and local authorities to deliver services to meet people's needs. I mean, as has been mentioned, we are in a mental health crisis. If you look at the census data, people self-disclosing mental health problems has more than doubled in the last 10 years and gone up quicker than any other group of illnesses or diseases. And for young people, that's gone up over 6 times. So we are in the midst of a crisis, and there is a significant disconnect between national policy and local delivery. The community wellbeing funds have been mentioned, and our position is they're very welcome. So we have the Adult Community Wellbeing Fund, and we've got the Children and Young People's Community Wellbeing Fund, and that's sort of been the flagship approach from the Scottish Government to tackle inequalities at a community level around mental health. And absolutely, they are delivering really good pieces of work, but by their nature, £15 million each, spread across third sector interfaces in terms of the adult fund or local authorities for the Children and Young People's Fund. That's a tiny piece of money trying to go a long way, and they're very project based. So there's a real lack of data about their overall impact on the mental health system and the people that they support. And I really do want to caveat by saying that fund is funding really important projects. We would like to see a much more systematic approach to community mental health. That's one of the reasons at SAMH why we are opening the NUCs, as I say, that network of mental health walk-in hubs, which will be free for people to access, as well as providing significant outreach, particularly to different communities trying to tackle some of those inequalities by identity or deprivation. But we are needing to self-fund that, so we are trying to develop that evidence and that case for a more systematic approach to community mental health going forward. But absolutely, yes, there's good policy direction, there's very good pieces of individual work which could broadly be termed prevention, at that kind of primary prevention all the way through to secondary and tertiary intervention. But it is very piecemeal. There's not enough done to collect the evidence to share good practice because the systems aren't there. But fundamentally, it comes down to funding. We have IGBs across the country closing services. Aberdeenshire, as I said earlier, defunded entirely their suicide prevention budget because it's not a statutory obligation for them to deliver that. And that's not necessarily the IGB's fault. They don't have the money. So there needs to come back to kind of fundamentals about how we design a system so it is effective and a value for money and makes those impacts on individuals and families and wider communities and society that supports. But fundamentally, there needs to be a fair funding package for local government. And I would say very clearly the third sector has a key role in that, and a fair funding package for third sector delivery organisations, which are still subject generally to annual funding cycles, which are constrained. So we need to make much quicker progress to multi-year funding at that local level, so that we can develop those innovative projects and actually have confidence that they will be retained and not just slashed or closed on a kind of annual basis.
Thanks. Anyone else on this point?
Just briefly, I think there's no getting away from the fact that if you're talking about prioritising certain things, you're also talking about deprioritising other things.
Yeah.
So, I think we have to acknowledge that reality, and perhaps preempting what the next set of witnesses are going to tell you. But I think we have to think about what's the process for doing that, and how do you bring people along in that process. And I think, again, there is potentially a role for a human rights-based approach, which thinks about what are the minimum core obligations. So what is it that everybody in society should be entitled to? I mean, you talk about access to healthcare, for example. I mean, there should be certain kinds of healthcare that people should just have a right to, and we need to ensure that everybody has a right to it. There may be other things, particularly in the areas of emerging need, where we just have to say, well, we're not yet in a position to do all that we would like to do for this group whose needs have emerged more recently. But the concept of progressive realisation is about, well, how do we get there? What's going to be different in 10 years' time that might allow us to say that even if we can't do everything we'd want to now, we will have a structured and concrete and targeted process to accommodate the needs that perhaps we can't meet just now because the systems are not set up to meet them. So I think there's no getting away from the hard choices, but there are choices about how you make those choices.
Can I just briefly come back as well, Mr Harvey? Colin's absolutely right. These are choices that have to be made. They're hard choices. But in some respects, they're political choices that have to be made as well in terms of the allocation of scarce resources. So that's pretty fundamental to that. You mentioned a litany of issues and challenges that you're having to deal with in your constituency, which we're all very familiar with in relation to that. Let me give you one example of something that is working well. And I don't overlap in your other area of inquiry, which is on ASD and ADHD pathways. Mental Health Foundation, however, is involved in a project in Dundee called Together to Thrive, and one of your fellow members, Joe Fitzpatrick, has been to see it. It's in his constituency. Essentially what that project does is provide support through a sort of task-sharing approach, a partnership between the Mental Health Foundation, CAMHS, the local authority, local primary schools as well, in order to support parents of children with neurodevelopmental support needs to actually manage aspects of their behaviour which can encroach upon their mental health as well. So it's a project that is working effectively. It's been evaluated recently, and it shows where there are opportunities and actual practice that is making a difference to kids' lives in effect. Now that's a particular project in a particular locality. There is no reason whatsoever why something like that could not be scaled up, with a caveat about available resources, of course, but scaled up in order to actually make a contribution to an area of public policy that is extremely challenging that you as a committee are dealing with.
Can I put one final question then, which is just in response to quite a few of your comments. All of the witnesses have talked about the need for cross-governmental approaches, that we're not just seeing this as health budgets in isolation. Also to the heavy emphasis that there's been on having a more systematic approach to gathering the data and the evidence that preventative approaches work. Can I play devil's advocate a little bit on that and suggest that actually maybe we need to be less focused on the evidence and the data? Because if out there somewhere there's a parallel world in which Scotland has already got to grips with this and has already really deeply embedded a preventative approach to health, including mental health, right across government, can I suggest that what's happening in economic policy, in transport policy, in food policy, in all sorts of other areas is that decisions are routinely being made in the knowledge that the health effects will not be felt for many, many years, and that the least cost or quickest options are often being set aside. The policy choices that will, boost economic growth or, whatever the other immediate objectives of government are not being prioritised, and government is accepting that actually the evidence for the health impact will be felt over a much longer time period than it is realistic to measure. And it's not just, I think Brian Whittle's right about the short-term political cycle, the 5-year cycle, but there's a much longer-term cycle of decades in people's lives over which the impact of genuine preventative approaches to health will be felt. And so do we not need to be just a little bit less rigorous in saying preventative approaches need to be able to show the same robust data that you would for, say, a vaccine programme?
Can I come back on that devil's advocate element, which I'm glad you've raised? I have some sympathy with the kind of framing of that as an issue, but I think it's fundamental. No, we need to have evidence. We've got evidence, frankly, of the challenges that people are facing in their everyday lives. We know that already. What we need is the political will translated into actual policy action, which is going to move the warm words of the rhetoric of frameworks into measurable, I will defend it, into measurable policies that are going to, or impactful policies that are going to make a difference to people's lives. It sounds trite to say that, but that's fundamentally what it is. And if we're talking here about time frames, there's a political cycle. Yes, there are issues in terms of fiscal sustainability of the public purse, as it were. But fundamentally, we do need to extend that time horizon, but we need to start acting now in relation to that. And we need an evidence base that we know already exists in terms of data across different organisations and within different entities, but we need to put them up in we need to connect them in a much more cohesive way. And frankly, that is only going to come from direction from parliamentarians and from government. And so we've talked about different approaches in terms of tracking spending, in terms of the need to go across different portfolios in order to actually look at difference in practice, a human rights approach in terms of budgeting and so on. We need to do all of that, and we need to do it in a way which can be evidenced, because we need to see that it's actually going to make the changes to people's lives in your constituency and everybody else's constituencies across the different elements that we're looking at. So if we don't do that, and if we don't have a focus that actually enables us to put the warm words of policy ambition into practical action, then the generational dimension of this is lost, but fundamentally as well, people's lives are going to be blighted and continue to be blighted in ways that they frankly should not be doing in 21st century Scotland.
I'll just come in on 2 points. I think in terms of evidence, the first place to start when you're trying to build an evidence base is to understand what your logic model is. And I think a lot more is needed in terms of transparency when decisions are being made to cut services, to actually scrutinise what's the, without needing a peer-reviewed journal that says this will have a negative impact on health, actually, what does the logic follow in terms of the impact that will have? I'm interim chair of the Equality Human Rights Budget Advisory Group, and that's something we've been asking for in the Equality and Fairer Scotland names. The companion document that goes with the budget that looks at equality and human rights. Equality Fairer Scotland budget statement. There we go. To actually, so not just to look at the good examples of where there's an increase in spending and the logic and the evidence that supports what that will produce, but also to look at we need an example of where decisions be made to cut funding, and for that transparency to follow through in what the people making that decision understand to be the short, medium, and long-term impacts of that. So I think that's a step we can do in that scrutiny space, and I think Parliament's got a role there. The other example I just want to talk about, where it does feel quite messy, and I do like your question, but on the issue of deaths from drugs, alcohol and suicide, of which we know mental health is a big part of that, we know that those deaths sort of peak in people's 40s and 50s, although obviously it depends, it's unique circumstances for everyone. But we are spending a lot of time and energy and money on the crisis intervention point there. And not a lot of thought is going into the primary prevention part of that. So I think there's a role for when we have any kind of big budget priority, a big crisis, be it economic inactivity, be it the drugs death crisis, to actually be able to properly scrutinise the response. Is it a crisis response only, or is it actually thinking about, well, what's going to happen for the next generation? Because in terms of the huge human cost, as well as the economic and social cost of what we're facing in terms of some of these crises, with attention earlier in people's lives, you can prevent a lot of that escalating and happening. It involves housing, it involves social security, it involves all of those portfolios. It then goes through into your early intervention spaces in the homelessness system, in the criminal justice system. These are all joined together, but we don't really have that debate when we get these big national crises. It's, well, we need to do something here now. And I think that's where we're really missing. We forget about prevention when some of these big crises emerge, and suddenly it's like, what are we going to do about this now?
Yeah.
And I think that is partly the an issue of scrutiny from the media and other places in terms of what are ministers doing about this right now. And I just do think there needs to be a bit more of, well, what are you going to do to prevent this from happening in the first place?
Thank you.
We're rapidly running out of time, and we've got one final theme to cover, so can I ask witnesses if they can be concise in their answers? That would be very helpful. Elena Whittam.
Much, Convener. We've already kind of touched massively on the theme that I was going to look at, which is about prioritisation approaches. And I'm really interested in understanding how integration authorities can actually use, perhaps programme budgeting and margin analysis approach, which we really delved into last week, when they seek to undertake setting their budgets at a local level in light of the resource pressures that are out there. But obviously with that aim of that progressive realisation over a period of time of preventative spend, everybody getting to a space where they have good mental health and any acute issues are addressed quickly. So I'm wondering, is that an approach that you recognise and that you would say needs to be done, to be transparent and to have those decisions taken that are understood by everyone, as opposed to just being that firefighting, salami slicing that we're seeing at the moment?
Start. I'm not an expert on PBMA approaches, but the principles of it, where you understand the totality of your programme budget, and then you are looking in detail at your at the marginal decisions that you're making, so where you're putting money up here and down there, and a system of prioritisation, so you at least are understanding, putting into some kind of systematic framework, understanding of of the decisions you're taking and how they align to an outcome, and then how you are prioritising on that basis. It makes a lot of sense, but I think my concern about that is it's a big leap from where we are now to where we need to be. It's potentially an approach that may work. I do not have enough knowledge and experience on it, but the principles of it make a lot of sense, actually understanding where you are now and then taking that approach where you are, looking at the decisions in front of you each year and being able to have a process where you're prioritising those. It feels like that's how you should do budgets on a yearly basis or a 3-yearly basis. So it does make sense to me. But I think it's, as I said, it feels like we're quite far away from being able to recommend that or know if that's the right approach in its specifics for what we're talking about today.
Is there a risk in employing that type of approach that you could end up with a kind of a head-down look as opposed to a wider look across different silos and actually how decision-makings extend beyond the immediate decision for that particular budget?
Absolutely. And I think when I was here last year with Cam Donaldson, we talked about this a little bit, that it's not an approach, if you're talking about the mental health budget, it's not an approach you can just say it has to be done within the mental health decision makers, because actually it's decisions across government will affect what's happening for demand of mental health services and for the well-being of the population as a whole. So if you are going to do it for mental health, you can't just base it within the health portfolio. I think that's the key thing. So you would need that buy-in from across different parts of government. But it's an approach that may, because it exists and it's an approach that is used and has a methodology behind it, it is something that could be explored on a wider basis. But fundamentally, yes, I agree, it can't just be within the health portfolio that it's happening if mental health is the subject of what you're looking at.
And if we think wider just to, a prioritisation approach, which obviously was issued, guidance from the Scottish Government in 2016, that's the kind of decision-making processes that should be utilised. The survey done of the integration authorities really showed a stark picture as to how that actually is looking on the ground. In the absence of something as direct as a PBMA approach, how do we get our integration authorities to actually use prioritisation? Do you have any suggestions in that space, considering the prevention agenda, but also the big reform that's needed? How do you do that in light of those things?
No, sorry, forgive me.
Well, just one sentence. I mean, I think the point about the programmes is they probably need to be at a larger level than an individual agency or an individual local authority. And so unless you get into issues around pooling budgets and moving resource around the system, I don't think it's going to work. So I think you need to think about what the other levers are that are going to facilitate money being moved from the place where it is now to the place where it would be to make a real difference.
And in that light, do you actually think that there needs to be perhaps some type of transformational reform type budget that is made available to actually drive those types of decision making from other places? So levering money and resource from other places into actually making those tough decisions. Because if not, you're going to be trying to make decisions in an ever reducing budgetary context, and that makes it really difficult.
I think, well, first of all, I agree entirely with what Emma was saying in terms of the approach. Yes, I think there's an opportunity to do that. I think that would have to be done or certainly examined in terms of looking at that. We're not looking at etch-a-sketch budgeting here, I suppose, but we are looking at quite a change in terms of the approach. And that issue about this public finance budget, obviously, but there are principles as well about how. So in terms of how you do that with regard to encouraging that type of approach, well, we've got a public service reform process that's been ongoing for some time that will go beyond the next election. There's maybe something to be explored, and I put it no stronger than this, in terms of what duties lie in terms of particular authorities and how those are actually in practice in relation to that, in terms of the type of reporting that's done and the mechanisms that are used in that regard. I think there's also more broadly an opportunity, and I'll come back to our Improving Scotland's Mental Health Fund concept idea about, this is a more specific point, but about harnessing resource from the public purse, but also from other sources to enable us to actually do the type of innovative, at scale, strategic resourcing that can be done to put activities and outputs and outcomes into practice that actually make a difference to people. So I think there's a whole bunch of stuff there that can be taken forward in that sense.
I guess finally for me, just in that vein, where do you think the role of community planning partners then are in that space? Because if community planning partners are the ones that actually take in all of those different elements of our society, where's their role in actually setting that kind of transformation agenda and driving forward the expectation as to how budgets are prioritised?
I think at that community level, that regional level, they have a very important role to play in that regard, and what that looks like in terms of decision-making processes and interaction with other governance structures. That needs a bit more thought than we have in about probably about 30 seconds, but I think it's certainly something in terms of how we put together, how we coordinate existing governance structures at the local and national level to bring all these factors into play in a much more cohesive way than we've been able to do so up to now. And that does, I'm afraid, mean grasping the challenge or trying to break that circuit between short-term focus and longer-term preventative investment.
Thanks very much. Thank you.
Thank you. Can I thank the panel for their evidence this morning, and we will suspend briefly to change witnesses. Welcome back, and we'll continue our previous agenda item by taking further oral evidence as part of the committee's pre-budget scrutiny for 2026 to 27. And I welcome to the committee Duncan Black, Chief Officer, Finance and Resources, Glasgow City Health and Social Care Partnership, and Hamish Hamilton, Chief Finance Officer, West Lothian Integrated Joint Board. And we'll move straight to questions, and Emma Harper.
Thanks, Convener. Good morning to you both. The previous session I found very, very interesting, and I know that our population health framework is a joint Scottish Government COSLA framework. I'm interested also in how we I suppose, look at how mental health funding is delivered in terms of integration joint boards, because some IGBs have different mental health approaches, and so how do we then compare, and how do we know that some things are working well and others could be done differently?
Convener, thank you. So I can speak for the Glasgow City IJB, if that's helpful. So mental health services are a delegated function to the IJB, so that's very much a core part of the services we are responsible for directing back to health boards and council. The lion's share of the spend is in relation to health budgets, and the lion's share of the spend is also in relation to employee costs. So it's a central part of our strategic plan. You'll see it throughout that, and it's reflected very strongly in a lot of our performance information that you may have seen. In terms of how it's delivered, there's also elements of what we call hosted services, which I'm not sure if the committee is fully familiar with or not, but there are areas of specialist services that are hosted across the health board area. So, for example, specialist children's mental health services are hosted by East and Bartonshire Integrated Joint Board, and there are other pockets of that across the city. So there's delegated function to the Integrated Joint Board, and I'm pretty sure that's pretty constant across the country. Hamish won't maybe want to come in and describe what's happening in Lothian. But within that, there are elements of nuance around, as I say, hosted services, which are done at health board level.
Okay. And I think Hamish wanted to come in.
Yeah, thank you. So I guess in Lothian it's similar around our mental health arrangements with West Lothian, so my area being slightly different in that we actually, our HSCP, which is very coterminous of the Integration Joint Board, we manage a lot of the services ourselves. So we manage our own adult mental health inpatient services, right through to MHOs, support accommodation, care at home. So that's all done within West Lothian Health and Social Care Partnership. Whereas within the East Edinburgh and Mid Lothian Health and Social Care Partnership, what you have is similar to what Duncan's described in terms of the inpatient services are hosted. They're managed within an operational business unit within NHS Lothian on behalf of those IGBs, whereas the community services and the social care services sit within the HSCP. But again, I think between Lothian and Glasgow, what is helpful is that each area has multiple HSCPs stroke IGBs, so we can look at benchmarking and seeing how we compare to one another and try and learn from one another. So in Lothian we have a mental health and learning disabilities transformation programme, which has membership from across the 4 IGBs in terms of chief officers. I sit on it as one of the chief finance officers, and then we've got membership from NHS Lothian. So we have a number of work streams that are focused on trying to see what we can do better. But I suppose as well, just to finish, what is delegated to IGBs in terms of mental health is extremely complex across the country. I think Glasgow, maybe CAMHS is delegated to Glasgow City. CAMS is not delegated in Lothian at all. So making those comparisons across the country can sometimes be extremely complex, and you've probably seen that in the returns that you've had from IGBs.
I know other colleagues will come on to prevention, right, so I won't go down that route. Are there any changes you would like to see? I mean, I know everybody would probably say, yes, give us some more money, but are there changes that you think could be done to improve mental health?
Yeah, I suppose what I would point to are the asks that I would have are pretty strategic in nature, and I suppose to illustrate that, I maybe need to talk a little bit about the challenges that we have, certainly in Glasgow, but these are not just Glasgow problems. So I know you'll have heard evidence on this already, but to stress the point as strongly as I can, the level of demand is grown very significantly over the last number of years. Mm-hmm. The complexity of that demand is also grown very significantly. Obviously in Glasgow we have particular issues around poverty, and that brings with it comorbidities and the way that mental health needs to be addressed through things such as alcohol and drugs, etc. We have a huge additional consideration in Glasgow in relation to homelessness. We have 7,000 people in homelessness accommodation, and not entirely unrelated to that, we have issues around the communities that we're serving. So at the moment, I think there's about 169 languages spoken in Glasgow. So you have an incredibly complex environment. You have an increasing level of demand. And those two things together are bringing extraordinary pressures on the IJB and the services that the HSCP deliver. Funding is obviously crucial around that, and as we know, funding is restricted and is not able to meet that level of complexity of demand. So I suppose that the key asks that, as a Chief Finance Officer, I would have that would certainly help in that very challenging environment, firstly is around certainty, and I think the point was made earlier about multi-year budgeting, to get, and I know this is not in the gift entirely of the Scottish Parliament, but to get earlier and longer term, early notice of what our funding settlement is, and longer term certainty around that would be enormously helpful in terms of that strategic response to those crucial issues that I just outlined. I would also point to the issues, and this is perhaps more around the edges, but it's still an irritation, if I can put it that way, around non-recurring funding. So it does feel at times your hands are tied in terms of the agility of services, where you, as a CFO, I'm not able to permit, in some cases, the longer-term commitment to services if there's not underpinned by recurring funding. So by that, we're thinking about contracts with commissioning services, and we're thinking about contracts that employees have. So you have a number of service areas where there is more short-term approaches, which is obviously not helpful when it comes to that strategic response. And I suppose the final point I would also raise is around, it's probably two parts to it. New legislative asks. So, we do see, obviously, new legislation coming through the Scottish Parliament all the time, and that's the case as we speak just now. The ask from certainly myself is that in doing so that these any new duties are fully funded, because if they're not, then that just adds to the complex decisions that we have to take around the allocation of that finite resource. And I suppose the second part to that is around ring fencing, and I know it was alluded to earlier as a tool that can really be used by Scottish ministers to direct funding. But my slight pushback in that is that obviously that begins to undermine local agility, and you'll have all seen views from local organisations around that, and the fact that it begins to cut across what we can and cannot do with our finite budgets in that complex environment.
Just a wee final question. We talk about multi-annual funding, and it came up in the last panel with questions from Brian Whittle around, I suppose, around how we manage away from the politics, for instance, but full fiscal autonomy would allow us in Scotland to deliver policies independently. You know, right now, the last time we had the figures published, £600 million, so more than £500 million invested to help mitigate bedroom tax that has been implemented by another government. So, as well as multi-annual funding, wouldn't it be, as I suppose, beneficial to have better fiscal autonomy?
I just probably refer to my previous answer. From at a local level, as a CFO of an integrated joint board, it would be incredibly helpful to have greater certainty around your funding, both in terms of that forward look to the next financial year, but over multi-year. So if we can get a greater certainty around that, it allows us to plan more effectively, more strategically.
Okay.
I suppose just to add to that, we receive our funding from our partners, so from the Council and from NHS Lothian. We do not have certainty around our budgets until February, and we set our budget in March. And even with the way that it works for the health boards, the health board financial plans are normally indicative until April, so we're actually agreeing our budgets in March, which we're required to do with a caveat that the health board budget, may change, and we may have to come back to the integration joint board with a subsequent change. So, yeah, just to add a bit of context to what Duncan's already said in terms of the clarity.
Okay, thank you.
Thank you, Convener. Thanks to the panel members for coming today. We've heard from the previous panel about some of the difficulties on data collection and the picture it gives at a national level vis-à-vis local level. And there was a survey issued by the committee to integration authorities to try and just get a feel for data gathering. I think it's proven to be quite challenging to draw firm conclusions from the data gathered, and it's not clear that the format is comparable across different IGBs or health and social care partnerships because of the variation in delegation of mental health services and the different formats of gathering data. So just really to understand from your perspective, how and where do you report on mental health spending, and how do you categorise that spending as part of your wider financial controls process?
So I guess in West Lothian, I report to our integration joint board. We meet 7 times a year, and there will be regular updates to the board in terms of the forecast outturn for the year, so where we think we are going to be against our budget at the end of the year. And within that, mental health is a category both within social care and within health. So I suppose to put it into context, we've got a mental health budget for West Lothian IGB of around £38 million. So that's about 11% of our IGB budget. The majority of that sits in health, about just shy of £8 million sits within social care. So in terms of the detail that we get into in terms of the integration joint board and the discussion and the scrutiny around mental health, it does tend to focus on when there are financial pressures on the mental health budget. In the last year, that has predominantly been around social care. We overspent against the mental health budget in social care by about £800,000 last year, largely due to increases in demand and complexity. We also have, regular budget development sessions looking at savings for future years. But I would say, by and large, we have tried to protect the mental health budget. We haven't had to make extremely difficult choices there in terms of savings. We're still sort of focusing on efficiency, so reducing the cost of inputs. So, trying to get permanent staff as opposed to using expensive agency staff, and thinking about maybe where we can recruit nurses in places of maybe where we can't get doctors, and looking to do things differently. And within social care, we are looking to do more closer to home, around trying to reduce out of area residential spend. But our fiscal position is extremely challenging over the next 3 years. We've got a budget gap of £23 million as an IGB, with the majority of the pressure on the social care budget.
Yeah. So I suppose I could also give a flavour of the financial situation facing Glasgow in relation to that. Last year we had to come up with £42 million worth of savings as part of our budget setting. Within that, there was around £2 million allocated to mental health services. Kind of like Hamish is outlining, certainly there's a smaller proportion of our overall savings as a portion of overall spend that has been coming from mental health services as opposed to non-mental health services in HSCP. And that is a reflection, I think, of two things. The sheer scale of demand that I've outlined earlier and the complexity of that demand, but also in relation to the nature of that spend. A huge chunk of that spend is employee costs and fixed. So from a core accounting point of view, putting aside whether it's the right or wrong thing to do, it's not an area of cash flow savings, if I can put it that way, and that sounds a bit blunt, but that's the frank reality of it when it comes to the raw numbers of it. In terms of, I think your question was about the availability of the financial information and the comparability of that across the country. Certainly, similar to Hamish, in Glasgow we report regularly in terms of our budget, in terms of our monitoring, in terms of our outturn, initially through our integrated joint board and then subsequently onwards to our the health board and the council. Over and above that, of course, there's numerous layers of information that's requested by Scottish Government and other bodies where we can cut that information as is requested. As with any data collection, there's always an element of comparability and a lot of the devil's in the detail around that. But certainly, I think as CFOs, you'd have our commitment that we would, if there's an ask for information, we should be able to collect that for you, and we should be able to find ways around any comparability issues. Certainly within materiality levels that are useful.
We had clearly seen from the survey that was carried out by the committee that it is very difficult to get robust figures and how difficult it is to collect consistent and comparable data at the level of detail that would allow insights on how mental health budgets are being allocated. So how would you see a sort of consistent reporting of mental health spending at a national level functioning in relation to IGBs and health and social care partnerships? I mean, we discussed at previous sessions of the committee the idea of PBMA models, which could allow incremental real-time assessment of performance and allow adjustments of financing on a more consistent basis. I think one of our frustrations, certainly, that we've heard anecdotally is programmes are funded one year and then switched off the next year, and there seems to be a kind of reactive approach to overspends or saving requirements, which maybe aren't necessarily measuring value as opposed to trying to find cost savings. So just wondered, like, if you were designing the system with total control over what you could do to optimise its performance, what would you like to see improved if you were given that span of control? Just give us a sort of flavour of what you might see as frustrating from your perspective of trying to deliver high quality public service.
Sure. If I was go again initially, in Glasgow, HSCP, the Integrated Joint Board has asked officers to take a different approach to responding to the budget challenge over the next 3 years. In the past, we've had a savings target, and that's been allocated across services, and options have emerged from senior management around that. And to be fair, there has been nuance given to that around potential impact and assessment and comparing the adverse impacts across different options. So it's not entirely blunt, but what we are in the progress of implementing and looking ahead to the 26-27 budget setting and beyond for a 3-year period is a new the terminology we're using is service prioritisation approach, which on the face of it has certainly similarities to the PDMA approach that the committee has been hearing about in previous sessions. So this will be a really different and a new way to look at our budget setting process. Effectively, we are taking every single line in the budget, looking at it functionally, and also subjectively across the way to understand what is being spent initially. So, you know, you've got a similarity there around what you're actually spending your money on. So there's initial kind of understanding piece around that, and potentially sort of tidy ups to make sure things are getting reported in the right place. We're then going to apply a service prioritisation lens across that, each functional area over a 3-year period, to make sure we look at every single aspect of the HSCP's activity. We're going to apply critical success factors to that assessment, and effectively try and score each area against those. So, you know, the obvious factors that we'll be initially considering will be around: is it a delegated function? Is it something that we've been delegated and tasked to do? Is this a statutory function? And is it a strategic priority? And within that, thinking of each of our strategic priorities. I know we'll probably come on to it, but in terms of that preventative spend, that's the first strategic priority you see in our IJB strategic plan, is prevention and early intervention. So we'll be assessing each area of spend across various factors. As part of that, and this is where the real tricky bit will come in, we'll be looking at the evidence base for the impact of that spend and outcomes, and maybe go into that in further questions, but that I see as the main challenge around this, is the availability of impact and outcome evidence, and again it was touched on in a previous question, I think, in support of that assessment. But that's the intention, that's what we're going to try and do. So that will then allow us to effectively assess the impact of each area of spend across the IJB and identify which has the most impact within the kind of boundaries of statutory and non-statutory services, etc. If that's helpful.
That's helpful. And I just wonder if you had any insights as well as to optimising the process for reporting, and whether that, you know, can be consistent at a national level.
So I suppose the way that integration joint boards have been set up, each area, each individual IJB has its own integration scheme, which is locally. But so if you think about Lothian, it's between NHS Lothian and West Lothian Council for West Lothian. But the functions that West Lothian Council have chosen to delegate to the IJB are different to what Edinburgh Council has chosen to delegate to Edinburgh IJB, and you know, so I'm not sure there's an easy way to make everything consistent. You know, we don't have CAMS delegated in Lothian, but it is in Glasgow. And I suppose just on the reporting and the PBMA, I mean, I think it's a fantastic, you know, approach, and it is what we would strive to do. But if I zone in on mental health in particular, I'm not sure where we could stop doing something to invest in something else, because across this sort of full spectrum of our services, and we've got a finite amount of money, we are under immense pressure across all those services. So, and also there is that bit about we are a public-facing board, and getting decisions made that may be unpopular can be very challenging. And even if I just get very specific on neurodevelopmental disorders, we've seen our waiting list in West Lothian double from 2023 to 2025, and it's increased by about 900% since 2020. And that is not an area that we've taken any savings out of. That is just demand has exploded. So I think it's a very good principle and something that we would like to do, but actually making it happen, and Duncan's already touched on, the majority of our budgets are extremely fixed, and that they're staffing costs. You know, we can't suddenly not have our staff just because we want to, you know, do something different over here. And mental health is a very good example of an area which is extremely geared towards staffing costs. You know, if you looked at some of the acute services for big medicines budgets, where you may have new drug contracts that come into play, and you can take savings out and you can do something different. But our mental health budgets are predominantly staffing, very small non-pay budgets. It's statutory staff and commissioned staff.
It was a really interesting insight about the the extent to which demand has increased, and how that constrains your freedom of movement in terms of resource allocation. So I think that's something for us to give further consideration to. Thanks very much.
David Torrance.
Thank you, Convener. Good morning to witnesses. What evidence on outcomes do you use to inform spending decisions in relation to mental health budgets?
So I probably refer to my previous outline of our service prioritisation approach. And the intention there is to do exactly that, is to try and identify the evidence of the impact of the spend and assess how effective it is, which would then allow us to prioritise accordingly. Within the boundaries that Hamish has outlined in terms of what can and can't be adjusted, I suppose in my head I view it as sliding scales. So for mental health you have a sliding scale, and then you'll have stoppers on that scale, for example statutory levels of care that need to be provided that you can't go down. But the lens that we're going to be applying allows you to, in my view, see what it looks like if you reduce a level of spend in one area, albeit that is bound to have an impact that nobody particularly wants to see. But what does it allow you to protect or invest in certain other areas? So I think that's a panacea if we can get to that level of sophistication around our understanding of the impact of the money we're spending on frontline services, and therefore the prioritisation of that, using those kind of sliding scales, which allows you to look at areas of protection or investment, then that will put us in a pretty strong place. I think in terms of our kind of approach to date is very much where we can. Looking at prevention, early intervention, and there's various activity around that that we've undertaken in Glasgow, which I can perhaps go into, and the overriding principle of providing mental health services in the community wherever possible, and taking that out of hospital environments and transferring the care to community services. Again, there's challenge around that, of course, because in order to make that switch, the funding needs to follow, and that's often really hard. If you've got inpatient mental, certainly adult mental health bed capacity at 100% or often above 100%, to turn off beds to allow you to switch to community is a very difficult task. So we need to find some capacity and headroom to allow us to do that, because that's definitely where the strategic direction needs to take you, is that switch into community-based services wherever possible.
Yes, I suppose just to expand on what Duncan said around that, sort of one of our strategic priorities is around a home first approach, and I know there's been a lot of investment in home first from Scottish Government into unscheduled care, £100 million across Scotland this year, and I guess one of our priorities would be around looking to do something similar around mental health. So Duncan's already mentioned around adult inpatient services being often over 100% occupancy. How can we leverage and look to invest in our CMHTs, community mental health teams, our intensive home treatment teams, and do something similar around the mental health space? I suppose specifically on measuring outcomes, I think because of how we are set up in that sort of performance management environment, a lot of what we do is around measuring quantitative outcomes. So, how are we performing against our psychological therapies, waiting list, LDP standard, what is our bed occupancy, what is our length of stay? And I think where we would look to try and develop and try to improve is around measuring outcomes on the more qualitative, which is more difficult, but around how can we actually evidence that that early intervention and prevention and more focus on self-management, which is another, it's in our strategic plan as well. How can we evidence that the outcomes there are being delivered, and that is harder because the data is not as readily available, whereas what we are set up to do is to report routinely on our waiting list performance or our occupancy.
Around data collection and measuring outcomes, is financial restraint stopping you getting better data and information out there to make a better service? Because most of it's all spent on the frontline services.
I mean, sorry. Can you go? I mean, I would say absolutely, and I think having to prioritise frontline services, is where we are. I mean, we're constantly looking at what is our statutory provision, what do we have to do, in terms of finance and sort of priorities around data. In my time working within West Lothian, we used to have 7 individuals involved in the finance support to the HSCP VIGB, and it's now 4. So we've had to cut back on what we're able to do. And then when you think about systems and data, I mean, again, just to reference back to our £23 million budget gap over the next 3 years, that means that, as I've said, we're looking at what do we have to provide, what are our statutory services, to then have to be saying, oh, we would like to do something, in the background that will focus on data and, will give us a benefit potentially, down the road. I don't think that's something that I would be able to convince my board to support, given the fiscal environment as you've highlighted.
Convener, if I can. I think even with additional resource, it's a really hard thing to do. It's been talked about for a while, as I'm sure everyone is aware. There is source information we can use, and that's going to be our intention over the next years to try and use that. I suppose in the kind of standing back from it a wee bit, there is information out there that we've been subject to a very recent inspection of our children's services in Glasgow, and that's been given a good rating. That is a very in-depth and significant piece of inspection work that gives you a level of assurance around the impact of the services that children's services are having. Adults was done a few years ago, so there's information out there we can draw from. It's probably about just making sure we're tapping into as much as we can that's already out there. But it is a challenge. I think. Again, I think it was Harvey earlier, but I made reference to the fact that around the focus on prevention early and intervention, everyone accepts is the right thing to do. But when you're fighting fires to maintain statutory services, it does feel like you're doing 2 different things with each hand, and that will be the other challenge here. So, yeah, this won't be easy, but certainly I think there's space to do a bit more around identifying the good quality outcome impact information that we have. I agree with Hamish. I think when you look at performance information, it feels very, it all relates to waiting list times, it relates to bed capacity, etc. I think we need to get a bit more nuanced around that.
Thank you. Thank you.
Brian Whittle.
Thank you. Good morning, gentlemen. I'm going to go on the preventative spend. We heard in the last panel, I have a particular interest around the impact of diet and physical activity on health, and of course mental health as well. We also heard from other panel members that the impact on mental health of housing, of transport, of poverty. So it's a kind of multi-portfolio issue that we have here. So from your perspective, how can you look at at this priority on preventative spend, which wholeheartedly agree with? How do you follow the money? How do you justify that spend by measuring outcomes? Because as you know, we're all going to ask that question. How do you follow the money?
Convener, yeah. So I suppose it's interesting when you look at the returns that you had from IJBs around, and I think it was picked up by Spice. What do you mean by preventative spend? It's the terminology around that. Mm-hmm. So I think in Glasgow we came up with a figure of 10 million. But to be honest with you, it depends where you draw the line with that. So there's a thing about language there and about specifically what we're alluding to. But that said, you know, there's a whole host of things that come into play when it comes to preventive spend that's going on at the current point in time. So, you know, there's numerous examples I could point to in Glasgow. We've got the Youth Health Service and the Child Young People Networking Team. So they support families throughout Glasgow. That's a focus on early intervention and prevention. Digital is clearly a massive area of focus to get that early intervention access to information and support for people who are maybe not as in need of such acute care at that point in time, and trying to short circuit that through accessibility of information and self-support in the digital side of things. So for example, and again some of these I think are not just Glasgow services, but in Glasgow we've got Cooth, which is a free online mental health digital support service for 10 to 16-year-olds. That's like a text-based counselling service and with self-help material. Similarly, we've got Together All, which is another free online mental health support resource for communities. And there are other examples where we provide early access to support for people at higher risk of developing mental health. So we fund the GAMH service, Compassionate Distress Response Service, which is a phone-based support for people in emotional distress. I'd probably refer the committee to our performance report, which outlines some of these things and also gives some useful case studies. I think case studies is a useful tool to try and get about impacts and outcomes, because it gives you that sense of what that can actually mean for people on the ground. But yeah, the trick will be, as part of the exercise that I'll be working on over the next 2 years, will be how do we capture that in a meaningful way that allows us to take strategic decisions on allocating spend. And that has to be an evidence base around that, I think. Again, there was an earlier question around, or challenge around that, you know, how much evidence does it have to be around this? But from my perspective, I do need to see a certain level of certainty rather than an assumption around protecting area of spend because of the sheer pressure on the budget.
So similarly, I mean, we have a number of areas that we would I'll maybe come on to that in a second, actually. So I suppose in terms of the differences that you've seen from IGBs around what is preventative spend, like Duncan, I found that incredibly interesting. I think it probably comes back to people's interpretation. I mean, I suppose I saw Dundee had highlighted that you could class all community and social care spend as preventative around mental health. So, I mean, for us in West Lothian, that'd be about £20 million. It'd be half of our budget on mental health is spent in primary, secondary and tertiary prevention. But, you know, it's very open to interpretation. I mean, in terms of, you mentioned physical activity and impact on mental health, we have a Excite referral programme, you know, in partnership with West Lothian Leisure, where people are referred by, could be referred by a GP or a community link worker or another health professional, and they'll then get lifestyle advice, nutritional advice from West Lothian Leisure activity programmes, and again that is around trying to use physical activity to support other treatment or maybe as an alternative to treatment to try and improve people's physical and or mental health. In terms of following the money on prevention and measuring outcomes, I'd agree with Duncan in terms of case studies can be quite powerful. You know, if I think about the programme I've just mentioned, how could we say that actually referring someone to the referral programme has prevented them perhaps needing to be taken on by the community mental health team and adding to their caseload? I'm not sure we can definitively make that link, but it's maybe back to the bit about getting better and qualitative information and what has helped people. And I think that is a real area that needs to be a focus for us. But I mean, I'd probably go back to that sometimes we do have to make those hard decisions around, you know, what is statutory spend, what are we absolutely required to do, and sometimes that can be at odds with some of the really good preventative measures, because some of those things may not be classed as statutory, and if you're faced with the savings targets that we're all faced with across the country, then sometimes you have to make those difficult decisions. But I think measuring outcomes around prevention should be a real area of focus, as Duncan's already highlighted.
I think it kind of got to the kind of crux of the matter there. So if we take, for example, improved housing. If you know, I think again we would all agree if we could get good quality housing for for those caught in that trap there, that would inevitably, as part of our outcome, would improve physical mental health, or improved public transport and the ability to get around would improve physical mental health. But that's budgets that are spent somewhere else that you're not spending, but the impact of that is being felt within the health budget. So, and there's the converse of that, of course, is true. Is it about time we had a wee look at how we, fuzzy the edges, for want of a better expression, around budgets and the potential impact across portfolio, and how do we justify that?
I'll take that, convener. I totally agree. I mean, personally, it feels like everything comes back to housing. If you can get good quality accommodation for people, then a whole host of spend down the track can be avoided or minimised. I think I totally agree with the premise and your argument. I think there's a practical element to this.
Mm-hmm.
This is going to be hard enough for us to do certainly within the Glasgow IJB budget environment. So I think it's a little bit of see how we go on with this, and then look at widening it out. Having said that, there are areas of good practice around this that I'm sure the committee will be familiar with. So, for example, in the Glasgow city area, there's been huge efforts in recent years around child poverty, and the impact that is being seen through that on wider budgets. So, again, it comes back to measuring this and demonstrating this through evidence, but it seems certainly to be the case that if some of the early intervention work on children's services and in child poverty hadn't happened, we can see cases where children would have ended up in very high cost care packages. And I think there's some really good examples within that we could probably provide to you that show that if it wasn't for that, our children's services budget would be in a much worse state of play, and our budget gap would be far exceeding the one that I'm reporting to you today. So, and whilst children's services as a delegated function, a lot of that work was done, out with the boundary, if you can call it that. You're right. We weren't being precious about what services we're talking about here. It was feeding into council, health board, other partners, etc. So there's definitely a lot in that. But I think it's a big ask to do it at that macro level, to flick that switch overnight. But there's a lot of mileage in it.
In terms of the premise, absolutely. I mean, I think health and social care, we've got quite a lot of good examples where we've been able to close inpatient beds. If you take learning disabilities, intellectual disabilities as an example, really long stay, people living in hospital, and close those beds and take that money and commission something in people's local community, so that they're supported to live locally. So that's been an example of where sort of breaking down what was traditionally the NHS budget and the council budget and bringing together integration joint boards, in terms of losing the fuzziness, I think you said, in terms of where the budget sit has been successful. I think going further than that and looking at areas like housing and how you can be more dynamic there is absolutely would be hugely beneficial. Housing, again, also comes up a lot in our local area as a sort of key issue, and determinants on mental health and physical health, as you've highlighted. But I think sometimes the systems don't allow you to work in that way, and I think a lot of it probably comes back to local relationships, if I'm being honest, and where you've got people that are happy to be flexible and happy to take more of a risk. But I mean, ultimately, some of the organisational barriers go up sometimes, and it does make it tricky. But I think as a principle, I would agree wholeheartedly that we should be looking across the public sector as much as we can.
Thank you. I'll leave it there just now, Convener.
Thank you. Patrick Harvey.
Thanks very much, Convener. Good morning. Still on prevention, as I did with the last panel, I'd like to ask two questions. One about the current state of affairs, and then a separate question about how we would be doing things differently if we were really serious about this. Before I ask the question about the current state of affairs, I feel it's really important to acknowledge the point that's been made that this is not about berating your organisations for the position that you're in, and some of the decisions that you're having to make are the result of a shared responsibility. And I think it's really important that we acknowledge that. Some of that's about legislative decisions that Parliament's made. Some of it's about budget decisions government have made. Some of it's about the UK approach to setting budgets late and having no multi-year funding for Scotland. So that has a knock-on effect. And some of it's about wider circumstances, you know, whether it's 15 years of austerity, whether it's the pandemic, whether it's the cost of living crisis, whether it's overpriced, insecure housing, underpaid and insecure work. All of these circumstances face us, and we have a shared responsibility for it. So I want to just acknowledge that before I come on to the decisions that some of your organisations are making in that context and may be unable to avoid making. Is it fair to say that what we're seeing is prevention being put into the government's strategies and plans and policies, but decisions being made routinely to cut really, really important services that act in the interests of preventing poor health outcomes and poor mental health outcomes? I mentioned in the earlier session community mental health teams, specialist trauma support, counselling for survivors of sexual violence, employability support, ADHD assessments for adults. All of these things have been subject to cuts just in my own area alone, and there'll be similar stuff happening around the country. So I said firefighting while we're setting fires, you know, to torture another metaphor. We're forcing people to try and run up the down escalator to get anything done here. Is that a fair, accurate assessment of the current situation?
Convener, yeah. It's certainly fair to say that the scale of the financial challenge that we have faced in recent years and are facing over the foreseeable future is such that it makes it enormously difficult to find investment in activity that is not delivering immediate services in terms of statutory care, etc. So a huge proportion of our budget is set against providing statutory levels of care, or care that is incredibly hard to shift to be delivered in a different fashion without time, space and frankly money to do that. So I would agree with the assessment that it's really hard to do that. As I said in my previous answer, it's not that there is nothing happening in that space. I've alluded to a few examples in Glasgow where early intervention prevention has happened and continues to work. I think what I would probably put my hand up and say is that we need to get a lot better at capturing that information and talking about it and using it to inform decision making. I think, you know, a lot of it happens and we're not necessarily capturing it and categorising it as such, which is where our new approach will hopefully come in to try and pick a lot of that up. But certainly the scale of the challenge is such that, you know, it is incredibly difficult. What I would probably just finish by saying, just to reassure the committee, as I said in my opening remarks, is that if you look at our strategic plan, prevention and early intervention is our first strategic priority. So it is the first thing that we should be thinking about as an IJB when we are setting policies and creating our strategies. So it is very much at the forefront of our mind. We don't need to be reminded of the importance of it, and we will be applying it wherever we can in our future budget decisions, whether it's on mental health or our wider budget.
So in short, when we do see the Scottish Government's budget, this is pre-budget scrutiny, we haven't seen it yet, when we see the Scottish budget, how should we judge whether it is going to continue to put yourselves and other organisations in that invidious position, or whether it is going to be adequate to start to allow us to take prevention commitments from policy into reality? What's the test?
So in terms of So how is the Scottish Government going to, how can you get assurance that it is putting preventative measures at the forefront? I mean, I think the budget is set at such a macro level that I certainly wouldn't like to comment on how you can get that assurance from the budget. I mean, what we tend to get from the budget is around what is your uplift. You know, and even to us in integration joint boards, as I've already said, it's February until we get the detail of what the budget means for us, because local authorities have to work through what the budget means for them, and then health boards have to work through what it means for them. And I mean, ultimately there'll be specific policy commitments. You know, I think I've already referenced £100 million for unscheduled care, but it's part of what year are we in? 25-26 budget. And there'll be the headline around, you know, what is the baseline uplift for health boards, or maybe what's been agreed for pay, although we've got a 2-year pay deal for health at the minute. In terms of how do you take that macro level document and get assurance around how preventative activities are being prioritised, I wouldn't like to comment on that.
Okay, I'm not sure any of us are going to want to be able to comment on it, even when we see the budget in that case. Finally, if we were in a situation where we were already taking a much deeper approach to prevention in relation to mental health and the other challenges that we're facing, in how we do cross-governmental working, in how we shift within budgets, and indeed how we try to prevent some of the bad actors in the private sector from making decisions that impact negatively on people's health and well-being. If we were doing that, is it reasonable to say that we would still be holding some of these preventative health investment decisions to the same evidential standard? Because some of these decisions are, by definition, really, really long-term, and they're only going to have a payoff over a period of many, many years, potentially even decades. How do we get to a point where people can make and justify decisions like that, which really cannot be evidenced in the way that a short-term decision can be?
Convener, that's a question that I and the rest of my senior management team have been grappling with when we're thinking about our new service prioritisation approach that we're going to be applying. What's the time frame lens, and what's the evidential requirement for us to tick that box? This is probably not the answer you may be looking for, but the answer is that I've struck on is that I'm not producing a calculator here that's going to throw out a yes or no answer. It's going to be much more subjective than that.
Okay.
But it is a can opener, so it allows you to begin to ask those questions, begin to look into the impact of that service, have that that slightly broader lens than perhaps might have been done in traditional terms, and it allows that same lens to be applied across the piece as well, which I think is a really important part. So you're not just looking at functional areas in isolation. But I think it's a fair challenge, and there will be a point at which you have to say, well, you know, I'm more attracted to something that's going to save me money within the next 5 years than I am with something in the next 40 years. And I say that as somebody that tends to think in macro terms, and I quite like that. But the reality of budget setting and public finances, that I think that's where you're going to end up.
Anything to add?
I think in terms of one-year budgets, it's incredibly challenging.
Yeah.
I think as well, I mean, certainly for my own area, we had earmarked what we were calling our transformation fund, which was to try and enable, you know, good pieces of work to be taken forward that would transform services for the benefit of people in West Lothian. That fund ended up having to be used to go to the bottom line to balance the budget because of the pressures that we're seeing on, I think you use firefighting, but you know, the day-to-day pressures that we're under. I mean, I would absolutely agree that we should be looking at that 5-year period in terms of what can we do today, what can we take perhaps a financial risk on that will save money in 5 years. I mean, I think it's not mental health, but the weight management drugs are a good example of something that is extremely expensive right now, but in terms of what the downstream effects might be on reductions in type 2 diabetes and all the care that individuals might need, you know, that would be something that you would absolutely prioritise if money were available, because you would hope that in 5 years' time you would see, you know, big reductions in other services, as well as, you know, medicines probably coming off patent, etc., and reducing costs. But today, the cost of that would absolutely blow our budget. So the decision, as you've highlighted, is around the firefight in the short term. How do we balance the budget? So I think a 5-year, you know, 3 5-year budgets would be something that we would really appreciate in terms of enabling us to do some longer term planning and to actually do the sort of scenario modelling that Duncan's highlighted.
Okay, thank you both.
Paul Sweeney.
Thank you, Convener. Just wanted to ask about this issue. So obviously we've had capital and revenue budgets split since 1998, and there's this sort of proposal about having a third component, which is preventative expenditure. I'm just wondering about a particular scenario. Obviously in Glasgow it's particularly acute around homelessness services, so I understand there's an overspend in the current financial year of 27 million, and that's forecast to increase next year, which is a kind of automatic stabiliser almost, because your statutory obligation is to meet that need, which can create an uncontrolled spiral in terms of expenditure. Then it turns to, well, what could that opportunity cost be in terms of capital investment in housing stock and expanding housing acquisition, supply, etc. But that's not necessarily within your control as an IGB HSCP. So if you want to actually achieve a mental health outcome, one of the foundations of good mental health would be, you know, a hierarchy of needs, shelter, housing. How do you break that silo when it's quite clear that you're treating a symptom of a wider structural problem? And how would, you know, truly the essence of preventative spend would be to punch through that silo and actually have a cross-cutting approach to dealing with that immediate crisis? How is that particular scenario playing out? Because it seems to me like quite a looming crisis in Glasgow, certainly. I'm not sure, it was probably in other parts of Scotland as well, but it just seems to me that we're straitjacketed in terms of our capacity to bring public resources to bear to meet it in a structural way and a preventative way, rather than just simply treating the symptoms of hiring, renting hotels, for example, as opposed to building new stock.
Yeah, Convener, yeah. So homelessness is a delegated function to the Glasgow IGB from the council. So the spend and direction of service delivery around that is within the IGB's remit. As you've outlined, Mr Sweeney, the current year projected overspend is significant, and going into next year, that is going to grow to in the region of £60 million of a pressure, which is just enormously significant in the context of certainly the IGB's projected budget gap next year of between 30 and 40 million. You know, that's on top of it. The reason that it's not really appearing in my presentations to you today is because in the current year we have the undertaking from Glasgow City Council to fund that overspend, so they are carrying the risk around that. So regardless of, I suppose, who's carrying that financial risk, it is enormously significant for the council. The pressure that drives that, the figures that I've just alluded to, is purely around the provision of the housing requirement, so providing people with appropriate accommodation as is required under statute. What is not captured within that is the wider impact on the services that the city provides, and of course the IGB will be a big part of that. So when I was talking about the complexity of need, etc., in my opening statements, that's one of the things I was referring to, because you have people in either accommodation that is not ideal, or people who are in temporary accommodation, etc., and the impact that has on their mental health, for example, and the required services around that. I also alluded to the shift in the makeup of our communities, which has a big impact on the services that we deliver in terms of culture and language and all the rest of it, which adds complexity to the service response when it comes to health and social care partnership services. And the final component to it is also there's lots of legal costs associated with that, which does also hit these budget lines. So it's a huge issue for the city. I would say, arguably the biggest issue that we currently face financially. And yes, you're right. I mean, the solution to that can only be funding to address the immediate pressure, and it is an immediate pressure. But also in terms of solving the underlying issue is more housing. And obviously that's not within the IJB's remit, but that is around funding for housing supply and the types of houses that are required to house some of the families that we see presenting as homeless in the city.
Okay, thanks. And Elena Milton.
Thanks, Convener. Good morning to you both. I want to focus a little bit of time on prioritisation approaches. So you've already both touched on this and the evidence that you've already given to us. You yourself, Hamish, touched on the PBMA approach and perhaps the kind of difficulties with that. And Duncan, you spoke about looking at a kind of a slider and looking at how if you spend more here, what's going to happen here. I'm particularly interested in understanding your approaches as an integration authority when we have something like an in-year reduction in funding. So we saw that in 24-25 when we had an incoming UK government, decisions were taken which then impacted on Scottish Government budgets straight away. That then impacted on local budgets. How did you decide at that point in time where you were going to prioritise the spending? And you know, what was the fallout from that? We've heard about firefighting this morning, we've heard about decisions that had to be taken. Given the kind of context of the delegated functions, the statutory duties that you have, and the strategic plan that you're working to, how do you prioritise spending in those in-year budget reductions?
Yeah, so it's extremely challenging. If I may, the mental health outcomes framework is a good example of that happening. So, and there is a bit of a history there in 2022-23, it was December, so you're 3/4 of a way through the financial year before that funding was cut. So it was within NHS Lothian, it was 10.4 million the previous year, and it was cut to 9.2 million the year after. We didn't know that until December. So in reality, what that meant is we ran with a big overspend that year. There was not much we could actually do about it. Last year, it was October until the cut was known, so it was 6 months into the financial year before we were informed that the mental health outcomes framework was reduced by, I think it was 4.5 or 4.6%, so just shy of £1 million for Lothian. In terms of how we implemented that cut, we took quite a practical approach, if I could speak frankly, in that what can we actually do, and where can we reduce down the spend to now match that reduced envelope, and we looked at where we had temporary staff in place. So we made reductions of £250,000 in psychology, and although it's not delegated to me in West Lothian, the decision across Lothian was to also reduce £400,000 in terms of CAMS. And that was around where can we actually influence the spend. A large proportion of the mental health outcomes framework spend was quite historic, so 18 million in Lothian, 6 million of that related to Action 15 funding, which originated in 2017-18, which goes back to Vic Douglas made the point about funding being non-recurring for a number of years, and just shy of £3 million of it was related to the old mental health bundle, which is at least 10 years old. So actually we made the decision on where we could actually cut our costs, and that is the reality of the firefighting approach that we often find ourselves in.
So what do you think the long-term impact of that type of approach? So we've already been discussing it, the kind of year-to-year settlements that we have, the requirement for more resourcing, the overspends that we see in different parts. I've heard from my own health and social care partnership, it's around about social care is a major pressure, so that's where the overspends are. Duncan, you've got Glasgow Council itself willing to underwrite and support the overspend in the homelessness budget at the moment. In the absence of that, how are you going to actually protect that mental health spend going forward?
Well, I suppose to illustrate how Glasgow responded to the situation that Hamish outlined, and I don't have the exact detail, I only started in June, so I don't have the exact detail of how we responded, but my understanding is effectively that yes, there was a significant in-year cut to our funding that was not anticipated. So just to stress that point, it makes it really difficult from a financial management perspective. But what we were able to do across Greater Glasgow Health Board areas was to utilise earmarked reserves to bridge fund for a period of time to allow a more considered approach to how to respond to those levels of cuts. And this is, I suppose, an important point, is that the one thing in our favour is that IJBs are constituted as effective as local authorities, so we are able to hold reserve funds, and it's incredibly important that we do, because it allows some flexibility to respond to unexpected and in-year fluctuations in funding or indeed demand. So there's a proactive decision when that letter hit to say, right, let's utilise some earmarked reserves, bridge fund it, and then build that pressure into the budget setting framework in future years, so allows you to take a slightly more strategic approach to it. So the impact is really unwelcome and must be avoided at all costs for that kind of short notice in-year change in funding. And the only thing that we have really in our armoury to protect us against that is the use of reserves where we have them, and not all IJBs do, to allow that flexibility to deal with it in a slightly more strategic way.
I mean, especially I would imagine, given the fact that those reserves are going to be dwindling and you need to carry them at a certain level to be able to operate in a fiscally responsible way. Mm-hmm. So going forward, is there a need, I suppose, for an injection of some type of monies for reform to give that kind of head space to actually be able to look strategically, lift your head up from the firefighting aspect of it?
I mean, I fully expect to have no reserves by the end of this financial year, 2025-26. I expect to have no reserves, which, as Duncan's highlighted, makes me very... if there's an unexpected event, there's no way to cover it. And I suppose in terms of reform funding, I mean, absolutely. In terms of that sort of pump priming investment, weight management drugs or preventative spend in mental health that we think means we can, actually maybe boost CMHTs or intensive home treatment teams to then maybe take the pressure off the hospital sector. I know in Lothian we run over 100% bed occupancy constantly. Then that, reform funding to sort of pump prime that investment, that 5-year, time scale would be incredibly welcome. And I suppose just to round back on reserves, I mean, I have a reserves policy to try and hold general reserves at a minimum level of £2 million, which isn't much in the context of a £330 million budget. But actually getting back to holding reserves would mean I'd have to agree a budget that actually took out more savings than are required. And given the scale of the challenge, I can't see that being something that would be agreed. So I think sort of reform funding, transformational funding, pump prime funding, whatever you want to call it, would be incredibly helpful.
Yeah, so it is important to distinguish between level of reserves that as Section 95 officers of the IJBs that we see prudent, and generally you'll see that around 2% of your net expenditure budget. So in Glasgow we're in a slightly better position thanks to some good decisions by the IJB and officers before me, insofar as we're currently projected to outturn around 1.5 to 2% of general reserves, but that's for unexpected events that allow you to continue in a sustainable way. But you're right, ideally you would have an element of funding that you could utilise for spend that would effectively buy you savings in future years. That would be the ideal situation.
And finally, for me, Convener, I guess I'm always wondering about how we actually look above the silo that we're always operating in. So previously, when I was CAUSE's Community Wellbeing spokesperson, I had responsibility for looking at rapid rehousing transition plans and actually getting 32 councils to look beyond homelessness being just at the door of housing. Now, obviously, Glasgow's got a different situation in terms of delegated powers, but how can we ensure that the rest of a local area's siloed working actually looks at their responsibility for the mental health budget and what they can do that would help deliver on the what we're expecting as your strategy locally.
I'd probably push back a little bit on the assumption that the siloed working around mental health, for example, certainly in the Glasgow Health Board area, there's really good joint working across IGBs, across the 6 IGBs, and interlinking closely with the Health Board. There was a paper, which I'm sure we can share, that went to the Health Board or the CMT at the Health Board around a lot of this stuff about the mental health strategy for the wider Health Board and how the contribution from each IGB, including sharing of best practice. And it's important, as I said, to note the intricacies of how mental health services are delegated in different, and Hamish has alluded to that as well. There are a host of elements that are hosted by Glasgow or East Dunbartonshire, for example, across the whole Health Board area. So I would actually probably say that there's pretty strong joint working around the delivery of the strategy at Health Board area. Wider than that, I probably couldn't comment.
Yeah, I guess that's getting at your community planning partners and everybody, locally in an area working towards improving mental health, how that all joins up.
And similarly, in Lothian, I think I've already alluded to the fact that we have the Mental Health and Learning Disabilities Transformation Board, and in terms of the PBMA, the programme budgeting approach, we actually have undertaken a piece of work where we have quantified and set up a programme budget, across mental health and learning disabilities and intellectual disabilities within Lothian, which cuts across our 4 IGBs as well as the Health Board, and we can say actually, we can look at within Lothian what our spend is across the piece on adult mental health or on psychology or older people's mental health, in terms of using that to move things about and really to make decisions. That is where it does get more challenging, because as you've alluded to, you've got 5 separate partners. So, what may be a priority for one area will not be for another. But I think we do a lot around sharing best practice and trying to improve things for the Lothian system. But ultimately, you do have 5 organisations that each have their own individual budget, and they all have a requirement to balance that budget, and sometimes those things might be at odds with each other.
Yeah, thank you.
Thank you. Can I thank the witnesses for their attendance this morning. At next week's meeting, we'll take evidence from the Scottish Football Association and the Scottish Professional Football League on topical themes including sustainability of Scottish youth football and promoting children and young people's participation in sport and physical activity. And that concludes the public part of our meeting today.